Hi, my name's Mary Ackerley. I am an integrative psychiatrist who's been treating mainly chronic fatigue and mold patients for more than 10 years. I'm here with you today to talk about the neuropsychiatric effects of mast cell activation. So, what is mast cell disorder? This is the current definition of MCAS, chronic inappropriate production and release of the mast cell's large inventory of potent mediators, which, upon interaction with other cells throughout the body, cause most of the symptoms of mast cell disease. In other words, mast cells are the immune system's first responders. And another important point, this is not a rare illness. Published research shows the general prevalence in the population to be about 10 to 17% of the population. And in my clinical population of patients with chronic complex illness, I estimate the prevalence at about 60 to 70%. So mast cells are the body's first responders to injury, and notice the time frames of cytokine release for mast cells. Release of histamine, tryptase, and tumor necrosis factor are almost instantaneous. Leukotrienes and prostaglandins are within minutes. Mast cells can then actually manufacture and selectively release a number of well-known cytokines, such as MSH, TGF-beta, and interleukin-6. That is why they're called first responders. So when I started first treating a large number of mold patients, people would tell me about feeling suicidal almost immediately upon entering a moldy building. And of course, as a classically trained psychiatrist, I thought this was psychosomatic because it was so fast, and especially since the suicidal thoughts would disappear after walking out of the buildings. No, I knew suicidal ideation could be caused by inflammation and was linked to limbic dysfunction. Then I learned about mast cells and how fast they react. And then I found they're located in the brain, which I will show you. And in fact, they are located mostly in the limbic or emotional centers of the brain. So when I learned about mast cells, I realized I had found a plausible underlying physiological mechanism that explained the onset of suicidal ideation within minutes of walking into a water-damaged building. I use my understanding of where mast cells are located to start my diagnosis of a patient as having mast cell issues. Diagnosing an MCAS patient requires taking a good history and having a high degree of suspicion. I usually start by looking at the review of symptoms the patient has filled out, especially at the skin, looking for flushing, hives, dermatitis, at the lungs, looking for a history of asthma, bronchitis, and anaphylaxis, and at the GI system for reactivity to many foods, extreme diarrhea, or extreme constipation. When I see several of the symptom groups involved, such as lungs and skin, in a patient who looks hypermobile, I'm usually pretty comfortable talking about mast cells. What symptoms are most common in mast cell patients? Doctors who've been working with these patients have noticed two common symptom clusters. One is called the triad, consisting of mast cell, EDS hypermobility, and dysautonomia. Add autoimmunity and gastroparesis, and you have the pentad. So once I see MCAS or hypermobility, I start honing in on the rest of the above diagnoses. Now, occasionally, I do get patients without hypermobility who have the remaining diagnoses. But secretly, I believe medicine just hasn't discovered their collagen issue. And when doctors first learn about these symptom clusters, many begin to recognize a few patients in their current population, usually among the sickest, that they apply to. Today, I'm going to be especially talking about number 8 here, adverse child experiences, or ACEs. Now, Halsey is a popular singer who recently opened up in People about her diagnosis of MCAS, EDS, POTS, and autoimmunity. She reveals her experience of a typical pentad patient trying to get diagnosed. Her symptoms were not recognized as real, and she was called lazy, crazy, and anxious by friends and family. She saw many doctors, was given many diagnoses, most psychiatric. And I'd say at least half, probably more of my patients have been told something similar by a doctor who had no idea what they were really looking at. And the best term for that type of misdiagnosis? Gaslighting. Now, my talk today does focus on the brain. And yes, mast cells are in the brain, in the blood-brain barrier, where you'd expect to find them as part of the immune system, but also in the highest concentration inside the brain, the thalamus, hypothalamus, and cerebellum. Mast cells regulate blood-brain barrier permeability, also known as leaky brain, an important fact to remember. And in a private conversation with Dr. Theoharides, he felt the amygdala also contains mast cells. The ventral striatum, which is the caudate and putamen, has a dense innervation of histamine receptors, which may be why antihistamines can help akathisia. Now, it's often really pretty surprising to patients to learn that the brain itself produces histamine in the tuberomammillary nucleus of the posterior hypothalamus. Say that 3 times fast. You can see the distribution of histamine is widespread here and present in multiple regions, including those of the infamous limbic system, the thalamus, hippocampus, and amygdala, as well as the cerebellum. It's going to be your limbic system. Now, some histamine is needed for sleep-wake regulation, as well as motivation and cognitive focus. However, too much histamine is a problem. Succinctly, activation of mast cells in the brain by stress hormones leads to blood-brain barrier hyperpermeability and neuroinflammation. Mast cells can also restrict blood flow. And remember, the brain receives 15 to 20% of the body's blood supply, as well as 20 to 25% of the oxygen, even though it only makes up about 2% of the body's total weight. This is because brain cells will die if they don't receive a supply of oxygen-rich blood. So none of this is good chronically, as we will see. And also notice the mast cells release here of TGF-beta, a cytokine very familiar to most mold patients. Let's take a deeper dive into what does it mean when we say mast cells in the brain. This diagram shows that mast cells in the thalamus actually degranulate and secrete corticotropin-releasing hormone, histamine, interleukin-6, tumor necrosis factor, and tryptase. This means your brain yourself can be creating inflammation and pain by activating the pain pathways in the spinal cord. And for clarification, the release of histamine through degranulation is not the same as the release through neurons as a neurotransmitter. I know, a little complicated here. There are a number of chronic pain, neurological, and psychiatric illnesses associated with mast cells, according to Dr. Lawrence Afrin, who wrote the defining book of Mast Cell Activation Syndrome. And these include fibromyalgia, migraines, neuropathic pain, chronic regional pain syndrome, vulvodynia, and when I hear that diagnosis, as well as interstitial cystitis, I always think about mast cells. Neurological diagnoses include autism, multiple sclerosis, Alzheimer's disease, Parkinson's, and even neurofibromatosis, or elephant man disease. Other neuropsychiatric syndromes Afrin has identified include gratuitous upset or labile affect. The new term for this diagnosis would be limbic dysregulation. And also reported are motivation disorder, depression, ADHD, bipolar anxiety disorders, panic attacks, and psychosis, including visual hallucinations, PTSD, hyperventilation with tetany, disturbance of memory, word finding, and difficulties in concentrating. In other words, almost every neuropsychiatric symptom known that has been reported in a mast cell patient. The perception of danger takes place in the limbic system. This is a key point in discussing neuropsychiatric illness, limbic dysregulation, and mast cells. If you remember nothing else, please understand the perception of danger takes place in the limbic system, in the emotional center of the brain. The presence of mast cells in the thalamus amplifies sensitivity by releasing the inflammatory cytokines corticotropin releasing hormone, histamine, interleukin-6, tumor necrosis factor, and tryptase. This leads to looping or amplification of stress, fear, and anger. And this is the crux of many neuropsychiatric issues, as well as a major contributor to the prolongation of chronic inflammatory illnesses such as SIRS or MCAS. Let that sink in for a moment. It's really an important point. So this is how stress destabilizes mast cell in more physiological detail. When the hypothalamus releases corticotropin releasing hormone, it travels to the adrenals, setting off the release of other stress hormones such as cortisol, glucocorticoids, and norepinephrine, as well to other regions of the brain, setting off mast cells in the brain. And over the years, and it's taken me some time, I've begun to appreciate that stress is just not a word. For many patients, it may be the strongest, most pervasive mast cell trigger they have. So let's look more closely at the physiological reactions underlying what is now called the trauma response. Our traumatic stress response involves the autonomic nervous system alternating activation in a very predictable pattern. First, our sympathetic nervous system takes off. We feel our heart rate rise, our pupils widen, letting in more light, palms are sweaty, familiar to everyone, right? But as the sympathetic activations threatens to overwhelm the system, a breaker switch gets thrown and the parasympathetic system predominates. You may feel frozen, unable to think or move. And oftentimes patients who are ill with mast cell disorders are stuck in one of these two responses: fight, flight, or freeze. And remember, this is a mammalian response from the autonomic nervous system dysregulation. And in fact, recent studies and observations suggest that even whales and dolphins are showing signs of PTSD. Now, I'm taking the time today to go over the characteristic responses of our body to both sympathetic and parasympathetic innervation because it's useful for diagnosis. Many patients collect essentially a goodie bag of diagnoses, and they have no idea that most are related to the dysfunction of their autonomic nervous system. With telemedicine, I've been able to get a good look at people's eyes, and I can tell pretty quickly, am I talking to someone in sympathetic or parasympathetic dominance? And for interest, folks, studies have shown that liars' eyes often dilate while telling a lie. So when you listen to politicians, watch their eyes forget their words. Now, this is a reference slide for dominant, sympathetic, or parasympathetic. Remember, the key words for parasympathetic are rest and digest or feed and breed. A good deal of my patients' complaints are about how their GI system doesn't work and how they never have any restful sleep. I often hear other symptoms being mentioned, and I do refer to this list sometimes to try and remember which one is sympathetic and which ones are parasympathetic. This is another diagram showing the traumatic stress response. As activation, which most of us call anxiety, accelerates, we activate the fight or flight sympathetic nervous system. As the activation continues, our nervous system goes into overwhelm. I can't take it, is what you usually hear it said, and the emergency brake is pulled. We call this freeze. And remember, and it's really important, health lies in learning to use our accelerator and brakes effectively as needed. And this happens through connection with others and a sense of safety. It's called social engagement. And this state is best described as being alert, engaged, grounded, creative, curious, and compassionate. And clearly, this is the place most of us want to be most of the time. And when we're not in that state, most of us are usually in fight or flight or frozen. And this is where we get into major problems with health. And remember, the cell danger response is what happens here in freeze, and this is what keeps our mitochondria frozen. And this is what we're trying to release as we try and bring patients back to health. Now, I'm fascinated by the interwoven interplay of the physiological reactions of the nervous system and psychological states. And this diagram shows how psychiatric and physical diagnoses are related to stress, to the stress response. Sympathetic arousal or fight is anger and aggression, and its associated diagnoses are bully, narcissist, sociopath, people on the warpath. Flight here is anxiety, sometimes seen as the busy bee, always doing, never resting. Panic and mood disorder associated with this, ADHD, OCD. Freeze is where the emergency brake is pulled on and the cell danger response engages. Here we're going to be seeing depression, chronic fatigue, and dissociation are some possible diagnoses. Now, in terms of polyvagal theory, the fawn response is one of the possible trauma responses that our body uses for survival purposes. The fawn response is complicated, involves both fight, flight, and freeze activation at the same time. And in general, it's a learned response to ongoing trauma. Psychological descriptions of this behavior can be called codependence or victimhood. Oftentimes, it's fairly easy to recognize these patients. They're the people who seem to always be speaking well of you, to you, flattering you, the things you've done. And it might seem like it's a little over the top, and often it's an indication they're in fawn.